Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. My colleagues and I host these gatherings every month to discuss issues shaping 21st century American healthcare. With election year issues coming into focus, health policy is dominating much of the conversation in Washington today. We have three panelists with us today who are keen observers of what's going on in Washington. Jonah Comstock, editor-in-chief of PharmaForum, Ben Leonard, healthcare reporter at Politico, and John Wilkerson, Washington correspondent at Stat News. Good afternoon, and thank you all for joining us.
Hi.
I'd like to start by asking each of you what brought you to your current positions. John, what professional experiences led you to your role at Stat News?
I worked writing about healthcare for a little over 2 decades at another publication, Inside Health Policy. And in that time, I wrote a lot about Medicare, the Food and Drug Administration, drug pricing, and everything in between. Before that, I had just been a reporter at the AP out in Nevada, and I didn't have a healthcare focus at all. So I, like most reporters, I learned the beat by reporting on it.
Jonah, thank you for coming back again to the Northern Virginia Health Policy Forum. I know it's been a while. What professional experiences led you to your role at PharmaForum?
Yeah, so out of journalism school, after a brief stint at Psychology Today, I ended up at Moby Health News, covering the digital health, mobile health space, kind of just as it was emerging in 2012 onward. And that, when Moby Health News was acquired by HIMSS, sort of led me to leading all the media operations at HIMSS, which included healthcare IT news and healthcare finance news. So I ended up getting a pretty broad education in healthcare reporting. And then a few years ago, when I was looking for a change, I sort of found my way to PharmaForum and discovered that pharma is a whole different animal. So over the last 3 years, I've just been trying to learn the ins and outs of pharma. But I do still try to follow policy and politics, partly just as a hobbyist. Honestly, I'm a little bit of a politics junkie when I'm not at work. And PharmaForum, I should mention, is an international publication, so I also have had to start learning a little more about policy in the UK, the EU, and things like that.
Thanks. Ben, it was great to see you at the American Hospital Association conference recently. What led you to your role at Politico?
Yeah, so I was a 2020 college graduate. So right out of the gate, I was all COVID coverage basically. So that kind of was a crash course in the healthcare system and learned a lot. I was at the Baltimore Sun originally and then moved to Politico, where I started out as a health tech reporter and in the last couple of years have taken over the congressional healthcare beat and co-author the Pulse newsletter.
Going forward, I'd like to get a top-line look at the issues that each of you are most closely following in your reporting. So, Ben, let's stick with you. And can you let me know what issues you're following closely?
Yeah, so my beat's Congress, so I've been following what's been happening there, which for the next few months probably won't be a whole lot given the election year coming up. But some of the things that we're watching in terms of movement on is the pharmacy benefit reform management or pharmacy benefit PBM reform package, and that's been moving through the House and Senate, seeing where that goes, and then also telehealth in terms of whether these Medicare waivers, commercial market waivers will be made permanent or be temporarily extended again. And then, since Congress isn't doing a whole lot right now, also following the Biden administration, sort of racing to finalize a bunch of healthcare rules before the Congressional Review Act deadline to finalize them, which would basically make it a lot easier for Congress to overturn them if they don't get it done in the next month or so. And then also following what the Trump campaign is planning to do and a potential second Trump administration is planning to do on healthcare.
Great, thanks, Ben. John, what are the issues you're following at Stat News?
The same issues, plus I guess I'm following the tensions between the U.S. and China a bit too. there's a bill called the Biosecure Act that would all but ban a lot of China-based companies from doing business in the United States. There's you never know how Congress is going to pass something, whether it's going to attach it to something else, but there's a pretty decent chance that at the end of the year, when Congress deals with the National Defense Authorization Act, the NDAA, that there will at least be an effort, I think, to attach the Biosecure Act to that legislation.
Thanks, John. And Jonah, what's top of mind for you at Pharma Forum?
Yeah, so we cover pharma pretty broadly, so it's a lot of things right now. From a policy perspective, I've been going pretty deep on the Inflation Reduction Act. It's if you go to a pharma conference, that's what people are talking about from a politics perspective. It passed last year, but it's just now parts of it are phasing in, and the big part, the Medicare negotiation part, is kind of we're about to have a big moment when that first negotiated prices get revealed in September. Right after it passed, there were a bunch of lawsuits, so we've been following those. It looks like none of them are really going anywhere. And really just sort of trying to get a handle on how it's going to affect pharma and how they do business. So IRA is really big. Also cell and gene therapy, I think, and looking at what's happening with the FDA, with global regulators, and especially around like reimbursement policy on cell and gene therapy. How do we get these really exciting life-saving therapies to a point where people can actually afford them, and people outside of major metropolitan areas can actually access them? So those are a couple big ones.
Great. Thank you all. We're going to unpack all those issues over the next few minutes, but let's start off at a high level. We all know that there are more issues going on than just healthcare related issues. So overall, what do you think are the biggest issues that are going to drive voters to the polls in November, or make undecided voters change their minds? Jonah, let's start with you.
Sure. So I guess I have sort of been thinking this in terms of like our specialty of healthcare. I think the biggest healthcare related issue, of course, is going to be around abortion and reproductive health. I think in terms of motivating voters, and certainly that's something that the Democratic Party is betting on, and we've seen in past elections has been a motivator. The extent to which it is I think up for debate a little bit. But I think in terms of broad issues, it's the economy always, and then foreign policy. I think again, there's some debate. In fact, I was just reading, I think, Politico's coverage of sort of how much the Biden camp thinks that Gaza is going to affect actual voters and vote turnout. But I think that's certainly where a lot of the conversation is around the crisis there and the United States role. I'll let the other guys have some the other issues here.
John, what do you think the 50,000-foot view of the issues that are going to drive voters to the polls or make them change their minds in November are going to be?
Abortion is definitely at the top of the list. We're all going to say that one. There's this professor emeritus at Harvard. His name is Bob Blendon. And the thing that and a lot of reporters talk to him, that's why I bring him up. The thing that he always harps on is that much more so than in the past, voters today care about what affects them directly right now. So there's not a ton of that in healthcare other than abortion. So for instance, even on drug pricing, a lot of the negotiated prices don't take effect until 2026. So to the extent that they think that they can get credit for it, the administration is going to probably focus on what is already in effect, such as the caps on out-of-pocket spending and Medicare Part D, the caps on how much you have to spend on insulin, that kind of thing. But there's also been this tendency of late toward voters really wanting to see politicians put up a fight. I think Trump really started that. So I think that to the extent that Biden can find issues that he thinks he could be viewed as fighting against big pharma or fighting against Republicans. I think he will choose to do that. I don't know how much that's going to influence voters. I really do think that that abortion is the big one that's going to get people to go to the polls, but you will see other issues come up, usually through the lens of a fight.
Thanks. And Ben, this is what Politico is all about. So let's end with you on this round. What do you think the biggest issues are?
Yeah, I mean, you hit on a lot of, my thinking, John. I think, it's going to come down to, there are a couple issues on both sides that'll, gin up the base. For Democrats, it's issues like abortion, healthcare costs, democracy broadly. Republicans, it's issues like the economy, the border, crime, immigration, things like that. And then it'll come down to whether, how the people, the smaller and smaller group in the middle, what they think on those issues. And a lot of it comes down to pocketbook type issues. And, we have seen some of the, although the broader economic indicators have been looking better for Biden, in the past months, it hasn't necessarily translated to voter sentiment a ton, because, their cost of living is still high. And I think that'll be something important to watch, touching on your point about, the immediate issues right now.
Thanks. And let's stick with you, Ben, for a moment. Besides the reproductive health issue, drilling down to healthcare specifically, what are the key issues that President Biden and former President Trump are likely to mention on the campaign trail? And how do you anticipate those messages will play with voters?
Yeah, so I think the top issues that Biden is seeing, polling pretty high on are issues like lowering drug costs, insulin. You can't really hear him talk without him mentioning the $35 cap, and protecting Medicare, the Affordable Care Act, are things that he likes to harp on as well, more popular issues. Although it's unclear, how much that'll translate into actual votes. There's some other things on the margins that he likes to talk about, protecting access to mental health care. And on the other side of things, Trump doesn't have as clearly defined a vision, but he does like to talk about the most favored nations drug issue, and has had his musings about the Affordable Care Act. It's unclear how serious those are, but there are some people sort of in his orbit crafting plans for the future ahead. So we'll see how that all comes out. But healthcare is not as much of a winning issue for Republicans, so that most Republican political strategists would probably say stay away from it when you can.
Right. And Jonah, from the Pharma Forum perspective, what do you think the key issues the candidates are going to be talking about as it relates to healthcare?
Yeah, I agree with Ben. I think drug pricing is the big one, and I also am not sure how much it's actually going to move the needle. But I think it's worth pointing out that it's a weird issue politically because everyone's on the same side, and no one ever lost political points by saying that drug prices are too high and big pharma is charging too much. So you hear it from both sides. Now, the real differentiator is, are they actually getting anything done? I think Biden has a lot more to brag about than Trump does. Trump had a series of executive orders when he was in office. They didn't really do much of anything, and some of them may actually be counterproductive. In fact, one of the provisions of the Inflation Reduction Act is to delay the implementation of a Trump-era rule that was meant to lower costs by improving negotiation with PBMs, but the Congressional Budget Office just says it's going to cost the government a ton of money. So that said, it's not like Trump has generally considered the facts to be the most important thing in his campaign. The fact is that he does have some fuel for rhetoric on sort of saying that he's been working to lower drug prices and has lowered drug prices. So I assume that he will talk about that. But Biden has, as John said, we're not going to see the impact of the negotiation until 2026, but there are a bunch of other things in the IRA that have taken effect and that are showing a direct impact on people's pocketbooks. And so, that if anything is going to have an effect in drug pricing, I would assume it would be that, the person who's actually paying a lot less for insulin might vote based on that.
Thanks, Jonah. And John, what do you see are the big issues that the presidential candidates are going to talk about? Because we're going to turn to Congress next.
Yeah, I agree. We all seem to be agreeing on everything here. Trump has not honed his message on healthcare. He's definitely a little bit preoccupied right now, and I don't know that he's going to hone that message anytime soon. Also, it's just in his nature to completely flip-flop on everything. I mean that he was very much in support of Medicare drug price negotiation at the beginning of his administration and was dead set against it by the end. But having said that, he has, said that he wanted to repeal the Affordable Care Act. I'm sure that's gotten muddled since then. Democrats will use that against him. And as far as drug prices, I would assume Trump really likes the idea of looking at what other countries pay and then paying less than that. That's, the most favored nation policy. So I would assume that he would do that. During his past administration, he was, he was a big fan of short-term plans, what Democrats refer to as junk plans. So that could come back if he wins. And just as far as whom to see, if you're wondering, who's influencing him, I would say, the Heritage Foundation, America First Policy Institute, and Paragon. Those are think tanks out there that, if you're wondering what they're going to be whispering in his ear, then just pay attention, to what they have to say. Biden, during his last State of the Union, it was pretty light on healthcare. He has said he wants to negotiate more drug prices, so he wants to expand Medicare drug price negotiation. So if he were to win and Democrats were to, retain enough control of Congress that they could do that, I mean, I guess that could be something that they would fight for. That would be a very difficult thing to pull off. I think they would need to have full control, and even when they have had full control, they had to water down Medicare drug price negotiations. So I think that would be a very heavy lift. Potentially either of them could really lean in on, the Made in America policies, and really fight for like an industrial policy for life sciences in the United States. Both of them have already done that type of thing to some extent. And this fits in very much, again, with the, US-China tensions.
Great, thanks, John. And so, like I alluded to, let's turn to Congress. All the members of Congress and 1/3 of the senators and several governors are up for re-election. John, what's your prediction on the likelihood that the party in control in either house will change based on the upcoming election? And what could that mean for the healthcare agenda?
I'm going to take a pass on this one. I really don't. I have, as people like to say, I haven't looked at the map. I have not gamed out what the likelihood is in either the House or the Senate who's going to control things. So that would be, whatever I say, I will no doubt be wrong. But I will tell you that both sides are right now using this downtime to lay the groundwork for working with the other side should power shift.
Great. Thanks, John. And Jonah, do you have a prediction on whether the control of Congress in either house would change based on the upcoming election?
Yeah, I don't think it's a foregone conclusion in any direction. I've heard that obviously the current situation in the Republican House isn't inspiring a lot of confidence. But whether that actually means that the House is going to flip, I mean, there are a lot of like retirements and things that are like making that more likely. And then the Senate is a very hard battle for Democrats to hold, but not an impossible one. So honestly, like any outcome is in the realm of possibility. But I think what's when we talk about healthcare, broad kind of big changes in healthcare policy tend to be driven by the White House, right? We think about the ACA, we think about the IRA. So I think who holds the White House is going to be a big factor in sort of what the priorities are and what gets done. Even, obviously, like whether they're able to do it is going to be dependent on whether they have a majority in one or both houses. But, I would really I would think about like sort of Trump's agenda and Biden's agenda, and then whether they'll actually have the votes to pull it off. But I will yield to Ben's no doubt more nuanced analysis.
mean, I
And
think that-
Ben, what are your thoughts?
Yeah, I think the general consensus is the math is a lot harder for Democrats. It's there are people like John Tester, who's in Montana, up for re-election, which is just a really hard state for a Democrat to win in, and Sherrod Brown in Ohio. But I think, on the other side for Democrats, the House is probably it's probably leaning there, but the margins are so close that it's really hard to say. But I think, beyond that, the bigger picture is that divided government in some way is likely, whether that means, White House, Congress, probably see, some form of divided government. So it probably means, a focus on issues that with bipartisan appeal, because you have to be able to get them through. So, probably more of the same in terms of what we've been seeing in this Congress. If Republicans gain control, probably more private market stuff, working on the Inflation Reduction Act repeal, potentially, maybe things like that.
Thanks.
I
Ben,
don't.
oh, go ahead, Jonah.
I just don't think it's likely that they'll, it's just like the ACA. Like like once this stuff is in law, it's too popular with the people for it to be a good bet to spend a lot of energy trying to repeal it. I mean,
Yeah, no, I mean, I agree, but I think
Yeah.
some people will definitely, try to, make some noise about it at least.
Yeah, I think that's fair.
So, Ben, in one of your columns, you described the 2023 Congress as historically unproductive. How was it unproductive, and will 2024 be any different?
Yeah, well, I mean, the margins were super slim in both chambers, and very little of consequence was really signed into law. A lot of time was spent on the battle over the speakership. Mike Johnson is hanging on for dear life as we speak, although he does seem to be getting some more Democratic support if some Republicans try to boot him from his job. But only a couple of healthcare bills really passed last year, and they weren't super significant. And we'll probably see more of the same up until the end of the year. It's really hard to get legislating done before the election, and I assume we'll see a lot of action post-November. There a lot will try to be tacked on to the end of your spending package in terms of PBM reform, telehealth, plenty of other things. So I think that's sort of where all the legislating is going to happen, and it'll be a pretty quiet next few months.
John, I think everybody agrees it's going to be a quiet next few months, but if Congress is to pass some healthcare policies, what kind of policies do you think those would be?
Yeah, so Ben touched on a lot of them. I would add site neutral to the mix, and potentially drug shortages. After the election, when, before people have actually, left Congress, that lame duck period, that often offers an opportunity to work on a lot of these things. But a lot depends on who wins and who loses and what the dynamics are, and that's just really difficult to figure out right now. But so yeah, PBM reform is possible. Medicare physician payment reform is possible. Site neutral, drug shortages. Those are all things that are pretty bipartisan to some extent. So they could either be worked on during lame duck or during a divided Congress next year.
Yeah.
Thanks.
Longer
John,
shot, but I would tack biosimilars onto that. There is some energy to try to sort of keep pharma from gaming the biosimilars in various ways to delay their release and to keep them from making an impact on price. There's a bill, the Biosimilar Red Tape Act, that failed a couple years ago, but it's back. Yeah, but I think John pretty much hit on most of what I had.
Thanks, Jonah. John, you mentioned site neutral. For our audience who might not be following this as closely as you, can you describe a little bit about what site neutral is and why that's an issue, and what's happening now and what the legislation would do instead?
Yeah, sorry for the jargon. As journalists, we're not supposed to do that. So yeah, the general idea is to pay the same amount regardless of the setting. So if it's outpatient, inpatient, whatever, doctor office, you would pay the same amount for a service. I forget the specifics of that, of what's being considered right now. I actually haven't been following site neutral as closely as one of my fellow reporters. She usually takes care of that. So I don't know the specifics of what's being considered. I know that it's a little different in the House and Senate, which is not surprising. Oh, and hospitals hate it.
It feels like the same
And
conversation we were
that's why
having.
it matters, because there's a hospital in everybody's district. So it's difficult to do.
It sounds like the same conversations they were having when I was covering telehealth 7 years ago. So they called it parity then, but
So government funding set to run out on September 30th. And lawmakers passed fiscal year appropriations about 6 months late last month. Ben, you reported on the difficulty of funding the government in a presidential election year. What can we expect from Congress as we race against the shutdown deadline?
I think the winning money, overwhelming money, would be on another stopgap measure to fund the government through post-election. There's lawmakers were already very behind on the last year's appropriations, and the math is not really changing in terms of Republicans and Democrats in both chambers. So I would expect another temporary stopgap so that lawmakers can figure that out. And like John was saying, a lot will hinge on the outcome of the elections there too.
Jonah, do you agree?
Yeah, I think so. There's only so many times industry can freak out about a shutdown and then it doesn't happen before it starts to feel like going through the motions. There certainly are things in healthcare that would be quite affected if there were an actual shutdown. I know for pharma, a lot of the worry is about the FDA and clearances of things slowing to a crawl at a time when they like really need them to happen. But yeah, they seem to keep passing these stopgaps, which keep the government from shutting down, but also don't really like add big notable spending on anything. So it's sort of yeah.
So John, are we really going to have a government shutdown because Congress can't pass a spending bill on time this year, or is it like Jonah says and it's crying wolf?
I'm gonna sidestep your question and answer it a different way. I think for healthcare, September 1st isn't really the date to watch. I think December 31st is, and that's because when they did pass the last spending bill, they synced all the healthcare stuff to the expiration of telehealth flexibilities. So during the pandemic, the government, Congress, allowed doctors to use telehealth more easily. Patients really love it. Doctors really love it. They're going to renew it. This is something that people want. But because it's easier to, get to your doctor if you're just doing it over Zoom than it is to actually show up in person, this comes with a cost. And because of that cost, then that creates the opportunity to work on other things like PBM reform and site neutral again, those types of things that could help pay for the cost of extending telehealth flexibilities. Congress also could pretty easily just use some budget gimmicks to pay for telehealth. So I'm not sure that this creates a huge opportunity to do some of these other healthcare reforms, but at least it's a bit of it's an opening.
So, John, you mentioned PBM reform a couple of times. Can you describe what Congress sees as, it sounds like, a problem with the PBMs and a need to change what the pharmaceutical benefit managers are doing?
Yeah, so these are what people usually refer to as the drug middlemen. Congress didn't really do any, there was nothing in the Inflation Reduction Act that really affected the PBMs. They kind of got off on that one pretty easily. And so I think now it's their turn. It can affect what PBMs do, can affect the price that individual patients pay. It's also a big issue for independent pharmacies who say that PBMs are running them out of business by steering business to PBM-owned pharmacies and by charging them, fees that then make it impossible to even break even on the drugs that they dispense. So yeah, that's kind of the 30,000 foot version of it. Others might want to get more into, exactly how
Yeah.
all that works, but
Jonah, I assume you followed this pretty closely. And so maybe if you have anything to add about what are PBMs doing that makes Congress want to legislate about PBMs?
Yeah, PBMs have always been a popular, and I say this in a neutral way, but a popular punching bag for drug prices. Because if you're pharma and all of the fingers are pointed at you, saying that it's your greed and you're raising the prices, attacking PBMs is a really easy way to sort of say, like, look, there's these other people and they're not even making drugs and they're extracting a lot of money from the system. I think like it's very easy to attack PBMs. A lot of stakeholders do it, but there is a reason that we haven't just gotten rid of them yet, because they do play an important role in how the very convoluted U.S. drug market works, and they're pretty entrenched. So yeah, so like figuring out like how much money they're really just extracting from the system, what kind of value they're actually adding, and then figuring out how to sort of regulate and legislate around that is the challenge. But I do kind of like the chances of something passing if you can figure out the right thing, because I'm not sure who's defending them.
So, so Ben, anything to add on the PBM issues before we move to the next set of questions?
Yeah, no, I mean, they pretty much addressed it, they're, the pharmaceutical lobbies, had a pretty, coordinated campaign to, turn the attention to PBM. So, that's been an important factor in it as well.
Yeah, it's kind of funny to think like that the efforts to curtail pharma companies could have an effect in that way. Maybe if they don't make the pharma companies lower their prices, they'll at least get them on board as an ally to go after the PBMs.
Well, thank you. So, switching gears, some of you may remember the physician payment system that was based on the SGR, the Sustainable Growth Rate. And every year, Congress had to intervene with the so-called physician fix to, I guess, fix the payments that were made too low by the application of the SGR. Then after that, Congress passed reforms to the physician payment methodology. So we have the payment system we have today. Yet it seems like every year Congress has to intervene to change the way Medicare pays physicians because the payments are apparently too low. John, can you tell us a little bit about why that is and what's going on now?
yeah, to some extent. In preparation for this, I told myself I should review what I'd written in the past about the current system. The current system is still much better off for doctors than the old system was. Back when they replaced the sustainable growth rate, which was how they determined physician pay and Medicare until like 2015. Let's just think of this in terms of a pie. The pie was shrinking. The pie is no longer shrinking. But doctors are mad that it's not growing enough. This year, they got a little bit of a bonus. It was a smaller bonus than they got last year. And so they consider that a cut. And they're not happy with it. But the pie is not shrinking. Under the previous program, they were facing at some point like a 30% cut in the baseline of what they were supposed to be paid. So I'm sure that Congress will at some point revisit this, but we're not in as dire a situation as we were in the past.
Thanks, John. Ben, do you have thoughts on the physician payment reforms and what Congress may or may not do later this year?
Yeah, I mean, it's not an issue that I followed extremely closely, but I know there's been a Senate group that's formed on the issue recently, and it's obviously a complicated thing to fix, but it's the sort of issue that has to come up every year, so it's going to get attention, and the doctor lobby is strong, so they're going to continue to act on it. So, and it's the sort of thing that since there's a deadline every year, it can force legislating. So, it's going to be an issue that's on the agenda every year.
Great. Well, thank you both. And then let's go to Jonah, but shift our attention to technology. And there's some aspects that have attracted Congress's attention, such as artificial intelligence, telehealth, and some others. Jonah, what are your thoughts on the biotech issues that are going to attract attention?
Yeah, well, I guess in terms of like tech, we say tech bio, right? And it's supposed to biotech, but like the AI stuff, it's for some time we've been seeing AI used in drug development, like early drug development, molecule, and that's still pretty huge. What's going to be seen soon is actually the first of those drugs that were developed that way coming to market, and so that'll give some kind of positive use case one way or the other. But in the time that took to happen, obviously all of the AI conversation shifted towards Gen AI and large language models and chat GPTs and what have you. In terms of that piece of it, we see it in pharma used more on the marketing side. There's a lot of excitement there, to sort of streamline processes and lower prices. Clinical trial design, being able to generate like consent forms and things in different languages really easily. There's actually like a ton more like on the margin ways that AI makes clinical trials cheaper than you would think. And that's a pretty huge issue right now, is trying to make clinical trials cheaper. And then when you talk about data and clinical trials, obviously there's also a lot of conversation right now about synthetic data and synthetic controls, whether we can use big data and algorithms and historical data in certain cases in place of a placebo. And there's a lot of reasons to do that. And that isn't strictly an AI issue, but AI is kind of what's making it possible to do it at the level that people are starting to do it. And so then that is obviously an ongoing conversation, part of the ongoing conversation with the FDA about real world evidence that also includes digital health and sensors. So those are kind of some of the big buckets where we see AI. What we don't see a lot yet in Gen AI is like patient-facing applications, right? Where like ChatGPT is actually, somebody's going to it as for triage or as a doctor. I mean, that's the stuff that I think if people start really seriously exploring it, is going to need to be more heavily regulated. But obviously people are cautious around that as they should be, given the limitations of these models right now.
Thanks, Jonah. Ben, last October, President Biden issued an executive order calling for the responsible use of artificial intelligence, which included the healthcare context. Have you been seeing any follow-ups from that executive order, or what it means to use AI responsibly as opposed to other uses of AI?
Well, I mean, it's going to be a slow roll. There are a lot of deadlines within, 6 months or a year that they have to hit. And a lot of it's just, naming, chief AI officer for an agency, or coming up with a strategic plan. A lot of it is stuff that's going to take a lot of time to implement. And there have been some regulations from the Office of the National Coordinator for Health IT that are trying to, create some transparency in terms of algorithms, but there's a limited scope. It's basically things that are in EHRs. So it's fairly limited there. We're seeing Congress starting to think about it a little bit more. It's still pretty far out in terms of regulation of AI, but there's been a lot more talk about it, at least. So we're still in the very, very early stages at this point, both in terms of the administration and Congress.
Thanks, Ben. John, anything to add on the use of AI in healthcare before we move to the next topic?
I guess what I would say is that you know, this almost goes without saying, but I'll say it anyway, which is that AI is just, it's enormous, and I don't think we even know what we're dealing with yet. It's, you know, Jonah talked about it in drug development, and he talked about aspects of it in drug development that I had not even thought about. But it's also something that hospitals are going to use, doctors are going to use, device makers are going to use. Insurers already are using it. Stat ran a series on how United Health had been denying rehab care to people using AI. So it's going to come up in a lot of different ways, and the government is just now trying to get its hands around it.
Thanks, John. And sticking with sort of the technology theme, you know, there was the big Change Healthcare incident that got a lot of news, but that brought cybersecurity in general in healthcare into promoted it as an increasingly important topic. What should we know about cybersecurity in healthcare, and what should we be paying attention to, John?
I haven't been doing cybersecurity really at all, but even yesterday, something came up. The Federal Trade Commission Chair, Lena Khan, said that you know, the FTC is going to consider data when reviewing potential mergers. In other words, in addition to just like how much market power that a merged company would have, they're going to start looking at whether they would have so much data that if you were to hack them, that, you know, it would be a national security problem. So this is another one that's a big deal, and that can be attacked in a lot of different ways.
Jonah, thoughts on cybersecurity in healthcare and what we ought to be paying attention to?
Yeah, I think Change Healthcare really was kind of a wake-up call for a few different things, but not just the cybersecurity. I mean, I think we've all been dealing with ransomware in healthcare for years and years, but like, I mean, a lot of people didn't even know like what Change Healthcare was, much less that like so much of our country's health data ran through it. And so it's like one of those middlemen, revenue cycle management, payment cycle management. It's really, it kind of points to like these vulnerabilities like, that can be sort of like in, it's not your hospital, it's not your insurer, it's this other company that helps, does the pipes between them, and stuff like HIPAA kind of protects regulates those things sort of broadly under the banner of business associates. Yeah, I mean, I think we're still going to see the fallout from that. I imagine if you're a company that was like indirectly affected by the Change Healthcare breach, you're looking to see like, what could we have done differently? How can we hedge against that? Are we depending too much on one vendor for these things? Or maybe, maybe it won't change anything. But it's certainly like a pretty big event in the world of health IT.
Thanks, Jonah. And Ben, do you have thoughts on the impact of Change Healthcare or cybersecurity in general?
I mean, it's definitely, woke people up to the issue. It's been happening for years and years, and breaches are, on the rise, and it's become a patient safety issue. But, it has been pushing Congress to talk a little bit more about it. Minimum standards have been proposed before for, healthcare organizations that want to participate in Medicare, but that sort of boosts the momentum for that. HHS is talking about about them now. Hospitals are not going to be happy about that if that happens, but they're eyeing it in the next few years. So that'll be something to watch there. It has definitely ginned up the legislative and regulatory energy. Whether that's sustained or not is unclear.
Thank you. Ben, you mentioned telehealth extensions a couple of times. Is there any chance that Congress will make those telehealth flexibilities permanent, or are we going to see another sort of temporary extension when we get to revisit this again in 2025?
So, I mean, expanded telehealth is one of the most popular issues in healthcare in Congress right now. So there's no doubt that there will be at least a temporary extension, I think, at this point. You know, there are still lawmakers that are concerned about data, whether there's enough data on outcomes to, you know, sort of prove the concept permanently. And, you know, there are concerns about costs, how that'll get paid for, but, you know, but as John was saying, there could be some budget gimmicks to, you know, pay for that. It depends on how much it costs and what the CBO scores it at. There are also a couple other open questions about, you know, payment parity for in-person versus virtual care, the payment rates between those two and any differences there. And then some lawmakers are a little concerned about pushing people too much into virtual care and want to make sure the incentive is still there for in-person care. And that sort of plays in with the reimbursement rate issue as well. So I think we'll see some sort of extension, whether that's permanent or not. A lot of that's going to hinge on the cost and, you know, what sort of data comes out in the next months.
Great, thanks, Ben. And then, John, you mentioned you've been writing about international issues and China in particular. I was hoping that you could tell our audience what kinds of issues our audience should be paying attention to as far as it goes to China or other international healthcare issues.
Well, I guess I would watch for whether this becomes a race with China over biotechnology, or if it remains narrowly focused on protecting Americans' genetic information from falling into the hands of the Chinese military or Chinese Communist Party. I don't think that that has been settled yet. I do think that this really is part of a broader competition with China. I think we've in the past gotten involved in certain sectors, briefly were the lead, only to watch China really take it from us. Or not, if not just China, just some other part of the world. Taiwan is really semiconductors, but you see it in other sectors too. And I think they want to avoid biotechnology, or solar panels would be another good example. That one's definitely China. And I think we want to avoid that happening to biotechnology. That aside, the way that punishing Chinese companies could affect Americans is there could be some drug shortage issues with that. A lot of drugs are made in China and India. And you could potentially make it more expensive to develop drugs, which would have an effect on their prices. So this could, and again, you could get a lot of incentives for American companies, which would be good for American companies, whether that's tax breaks or how you're going to do it, investments into some kind of industrial effort to boost biotechnology in the United States. So there could be a lot of ramifications, and it kind of depends on whether this turns into some kind of Sputnik space race level thing, or if it stays pretty narrow and is just about making sure that our genetic information isn't handed over to adversarial countries.
Thanks. And Jonah, turning to the Medicare drug price negotiation program, I know you've been following that. Can you give our audience a little bit of an overview of the timing of that and the next steps and what you plan to see and what difference you think that makes?
Sure. So the IRA, the biggest kind of most contentious provision in it, allowed Medicare to negotiate drug prices with pharma for the first time since 2003. It allows them to negotiate the prices on 60 drugs eventually, 10 to start. Those 10 have to be picked from the list of most expensive Part D and Part B drugs, and there are a bunch of rules about what can and can't be on the list, including if there is a generic or a biosimilar, it can't be a candidate for negotiation. If it's been in the market for less than 9 years for a small molecule, or less than, or it has to have been, or less than 13 years for a biotech drug or a biologic. Sorry, that's the word that I was looking for. So that all happened last year when the act passed. What's happening now is the 10 drugs have been selected. Negotiation is underway. We don't know anything about what's happening in negotiation. It's behind closed doors. We won't know those negotiated prices until September 1st. What makes this really contentious in pharma is that pharma does not believe this is a negotiation because the way that the act is structured, HHS or not HHS, CMS kind of has all the power. They set a price, and pharma has to take it or leave it. And if they leave it, they either have to pay a huge excise tax, like a really mind-bogglingly huge excise tax, or they have to stop doing any business with Medicare at all altogether. So pharma sued, saying that this is an excessive fine under the Eighth Amendment, saying that this is compelled speech if they have to say that this is a fair negotiation when it isn't, kind of throwing a big fit. And basically, they're losing these many lawsuits because the legal principle is pretty sound that you're not really being compelled to do something if someone is just like giving you a really good deal and threatening to take it away, which is kind of the situation right now with pharma and Medicare. So now pharma is probably not going to be able to fight it legally. What they can do is they have to figure out how they're going to live with it, which might mean raising prices on other things to make up for the money that they're losing through this. I mean, the act is structured so that the drugs that are being picked out are kind of their cash cows. So they subsidize other R&D. And that's why pharma, I think that's their public line on why this is bad, is like, this is going to make us do less innovating. We're going to make less innovative drugs because we're not going to have the money to support R&D because that's what we use this extra money for. But how much that's just a line is, I won't comment, but I think you can draw some connections there. So that's kind of the overview. It's the 10 drugs those will kick in the price negotiation after everything's done. It kicks in 2026, and then there's 15 more in 2027, 15 more in 2028, and 20 more beyond that. I should correct myself earlier. Actually, these are only Part D drugs. Part B don't enter into till later on in the process. So I just info dumped a bunch, but the only other thing I'll say is that pharma is also a little bit upset about the distinction between small molecules and biologics with regard to the time before it's eligible for negotiation, because it disincentivizes small molecule drug development, and small molecules are still like a really good option for a lot of conditions. So they think that's a little bit of a sort of weird choice by the government in terms of impacting how they're focusing their pipeline and their R&D.
Ben, do you have thoughts on the price negotiation program under Medicare and what we could expect to see or what we should be paying attention to?
I mean, I haven't reported on it much, honestly, but that's more of our FDA team's purview. But they're gonna keep plugging through the motions and go through the steps required under law.
John, anything to add on drug price negotiation?
Yeah, as Jonah said, seems like the primary effort right now in Congress would be to push 9 years for small molecule drugs out to 13 years. The original idea of negotiation was that you would use two things to control drug prices. One is inflation rebates. And for that, drug companies would have to pay Medicare back when they raise the price of their drugs faster than the rate of inflation. But of course, then they could just launch their drugs at a very high rate, at a very high price initially, which would kind of neuter the inflation rebates. So then price negotiation was supposed to take care of that problem at launch. But there were a few Democrats who insisted that drugs be given a fair amount of time on the market before Medicare gets to negotiate the prices. And that's where this came out of. And then Congress decided, well, since we have exclusivities already in place, we'll just more or less use the way that we've used drug exclusivity where biologics get more time and small molecule drugs get less time. We'll just use that as a guide for when Medicare negotiation starts. And the only problem with that is that the way they did it, because they used exclusivity as a guide, you end up negotiating the price a lot of the time about the time that generics would enter the market anyway. So that then has created this additional problem. And so this was really a gimme. This, as much as that law was bad for the drug industry, this was something that was, was supposed to benefit the drug industry. And now they're taking it and they're trying to get more. Whether that's good or bad, I'm not going to pass judgment, but at least I think it helps to understand the history of how this came about and why they set the timelines the way that they did.
Great,
Yeah, I
thank you.
even heard all that, John. That's really interesting.
So thank you. I've got two final questions before we wrap up, and they're both going to be the same for all of you. So for the first one is, for our audience members who want to develop a relationship with you, what kind of information do you appreciate getting from the public? And let's start with you, Ben.
Yeah, I think, if you're working in the health policy space, always happy to grab coffee. Feel free to reach out. My email is bleonard@politico.com. The sort of stuff we follow is, legislative developments, going beyond just the bill introduction, if there's any movement in terms of committee, things like that. That's what we're interested in. So, happy to grab coffee with anyone.
And Jonah, what kind of information is helpful for you if we're just going to send something that we think you might like?
Yeah, well, scoops are always appreciated, and sometimes scoops are open secrets in the industry, but they haven't made their way to journalists yet. Yeah, I would say I get a lot of pitches from within the pharma industry, including small biotechs. They want to talk about what they're doing. So I'm always looking for the other perspectives that aren't being handed to me, especially patient perspectives, patient advocates. And so, yeah, my email box is always open. It's also always full, but but I do read everything, and I love to hear different perspectives from around the industry if it's around pharma related topics.
Thanks, Jonah. And John, what kind of information do you appreciate getting from the public?
I have a really difficult time setting rules about when to contact me and with what. Hey, look, if you think something's interesting and that it's not getting enough attention, go ahead and contact me. So I'll do like Ben. My email is john.wilkerson@statnews.com. @globe.com also works because we're owned by the Boston Globe. So I think that's kind of actually just like a dummy. Stat News is not actually, it actually goes to globe.com. But anyway, yeah, give us just whenever, however, if it's on your mind, let us know about it. I'm a Washington correspondent. That's my title. So a lot of what I do is is Capitol Hill stuff, but I also very much care about policy. I don't deal with business that much. We have separate reporters who do that. I'm also not a science writer. But if you contact me and the information is interesting and it's not really my beat, I will pass it on to who's, to the right person.
Thanks, John. And yeah, this is my final question, and then I'll let you guys go, but I really appreciate all your time and thoughtful comments. There was a lot of content today that you guys provided to our audience. From Jonah, from your perspective, what's the one most important thing for our audience to remember from your remarks today?
That's a great question. I guess I just say that, even though it passed a year ago, even though John might say that it's sort of a gimme, the IRA is still kind of one of the biggest talking points anytime I go to a pharma conference. And the industry is very interested and concerned about how it's going to affect what they do. And I think we're going to find out a lot on September 1st when we see what these negotiated prices actually are. Pharma's fear is that because CMS can negotiate at gunpoint, the prices are going to be really, really low. But we don't know that. They have a lot of rules about how they set them. They're supposed to base them on factors like what they cost to make. So that's, I think, what everybody's waiting to actually see the first set of negotiated prices. That will really tell us what the real effect of this law is or isn't.
And John, let me turn to you next. What's the one thing the audience should remember from your perspective today?
I agree with Jonah. The IRA is real. I think what's going on between the United States and China, those tensions are important, but it's still a little bit more hypothetical. So yeah, I mean, the IRA is here. There are a bunch of lawsuits that are working their way through. It's not looking great for the industry on those, but we still don't know how those are going to pan out. Or not, so yeah, the day that they release the prices on September 1st, that will be telling. If we're still paying more than other countries pay, then we're still paying more than other countries pay. Or if anybody can kind of like figure out what the net price is, and if we're still paying more than the net price, that will show you that Medicare is not really going that hard on this, which is either good or bad. Whether that's good or bad depends on where you sit, but it will at least be very telling.
And Ben, you get the final thought. What's the one thing you would want the audience to remember about your remarks today?
I'd say just feel free to reach out anytime. If, like John was saying, if there's something that's, you think is important and isn't getting enough attention, to reach out. And also just, in terms of Congress, I'd say, if you're an advocate for a certain issue, just be patient. It's going to be a long few months ahead of waiting, probably. So with not a lot of action.
Well, thank you all. This brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you to Jonah, John, and Ben for being with us and for your insider look at what's happening in health policy on Capitol Hill and in the Biden administration, and your look forward to the elections ahead. I also want to thank the members of our audience for joining us today and our applied policy team for putting this forum together. I want to give a special shout out to Donnie Lucas on Administrative Professionals Day. Thank you for your support and assistance. Everybody remember the administrative professionals, because today is Administrative Professionals Day. Before I close, in the chat, you'll find links to subscribe to our monthly newsletter and view our Northern Virginia Health Policy Forum website. Please take a look at those. And on a final note, be sure to join us for our next forum on May 22nd. We'll have two panelists from the Centers for Medicare and Medicaid Services, from the Center for Medicare and Medicaid Innovation in particular. Our panelists will be Dr. Purva Rawal, the Chief Strategy Officer at CMMI, and Dilly Sundamurthy, the Special Assistant to the Chief Strategy Officer at CMMI. Thank you for being with us today, and enjoy the rest of Administrative Professionals Day.